Good day. My name is Jacqueline Stenson, and I'm the manager of projects at the USC Center for Health Journalism. Thank you for joining us for our Health Matters webinar, Reproductive Healthcare in Post-Roe America. The legal landscape for reproductive health care has been changing rapidly since the Supreme Court overturned Roe v. Wade in June 2022. The 15 states that now ban abortion in all or most cases are home to more than a quarter of women of reproductive age and the majority of Black Americans. The battle over abortion access continues in our courtrooms across America, and earlier this month, a federal appeals court ruled to significantly restrict access to the abortion pill mifepristone, making it likely that the Supreme Court will determine the fate of the most common way of terminating pregnancy. Here to help inform us about the ongoing changes that are taking place in abortion access across America, the impact on individuals and families, and efforts to meet reproductive health care needs, we have three distinguished panelists. Caitlin Knowles-Myers is a professor of economics at Middlebury College and co-director of the Middlebury Initiative for Data and Digital Methods. She is currently focused on tracking the changing landscape of abortion access in the wake of Roe's demise and disseminating information through abortionaccessdashboard.org and Open Science Framework. She also is working on multiple projects measuring the effects of reductions in abortion access on demographic, health, and economic outcomes. She spearheaded the Economist amicus brief in Dobbs versus Jackson Women's Health, the Supreme Court case that ultimately overturned Roe v. Wade. Dr. Jamila Parrott is a board-certified obstetrician-gynecologist and a fellow of the American College of Obstetricians and Gynecologists and the Society of Family Planning. She has been president and CEO of Physicians for Reproductive Health since 2020. She uses her position as a physician advocate to bring attention to systemic inequities affecting access and health outcomes. Dr. Parrott has testified before Congress and spoken extensively with the media about family planning and abortion access. Kate Zernike is a national correspondent for the New York Times. She joined the paper in 2000 as an education reporter and has worked across the newsroom, including on the politics, styles, and science desks, and in the Washington Bureau as a congressional correspondent. She was a member of a team that shared the 2002 Pulitzer Prize for explanatory reporting for a series of stories about Al-Qaeda and the terrorist attacks of September 11. She is the author of The Exceptions, Nancy Hopkins, MIT, and the Fight for Women in Science, published this year and based on a story she broke as a reporter for the Boston Globe. She also is the author of Boiling Mad, Behind the Lines in Tea Party America, published in 2010. This webinar is made possible thanks to the generous support of the Commonwealth Fund, the National Institute for Healthcare Management Foundation, the California Endowment, and individual supporters like you. You can tweet about this webinar with the hashtag Post-Roe Webinar 2023. We will be archiving this conversation later today at centerforhealthjournalism.org. A word about our format today. We'll be hearing from our speakers first, and then we'll turn it over to the audience for your questions. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel. You also can write us there if you are experiencing any technical problems. Now let's get underway. Professor Myers, you were instrumental in filing a brief from economists in the Dobbs case before the Supreme Court, and you've been closely tracking the shifting landscape of abortion and the health and financial impacts when abortion is not accessible. Give us an overview of the landscape and tell us about the consequences you predicted in your court brief and how they are playing out more than a year after Roe was overturned.
All right, let me tackle that. It's a big one. I'm going to share my screen because I always come with data viz. And there we go. You should be seeing my slides and hopefully, not an embarrassing note page or anything. So I may be just a little bit paranoid on this subject, but I always have this sense when I show up to talk about abortion that there may be a portion of any audience wondering what an economist is doing in the room. Like, what is the role of an economist in this conversation? What can and should we say, and what shouldn't we? So the way I kind of think of our role here is to help provide evidence on the causal effects of abortion policy and abortion access on people's lives. We have a toolkit that is well suited for this type of work and that can address some really crucial issues about causality. And in fact, these issues were a pillar of Mississippi's argument in the Dobbs case to the Supreme Court about overturning Roe. One of several approaches that the state took in that case was to say, look, we understand that stare decisis is a very high bar. We understand that the court is going to historically be reluctant to overturn its own precedents. But we're here to say that in this particular case, there's really no reason to believe that there is what's called societal reliance on the Roe case. And what they say, these quotes are from an amicus brief supporting Mississippi, but there's also similar quotes in Mississippi's brief and in court opinions related to this. What they say is, look, it's impossible to answer this question. Has anybody ever relied on abortion access? Is there any reason to believe that abortion access has played a causal role in the progress of American people? And they also say at the same time, we know there's no causal link. Now, I think those two things are contradictory. I think you have to pick one of those arguments. You can't say we don't know and here's the answer. But in any event, economists would say, and we did say in our amicus brief in the Dobbs case, these are both wrong. We do have tools that allow us to provide evidence and forecasts of the effects of overturning Roe. We obtain that evidence using a set of statistical tools that are often called causal inference. I suspect that everybody in this webinar is very familiar with them. The gold standard here would be to run a randomized controlled trial, like a vaccine trial, where you randomly assign a group of individuals to receive an intervention, randomly assign another group not to, or to receive a placebo or some other intervention. You compare their outcomes. Now, in the case of isolating and measuring the impacts of abortion policy on people's lives, we usually, occasionally we can, but we usually cannot design any sort of RCT. It wouldn't be feasible, it wouldn't be ethical. I don't have a time machine. I can't go back and, randomize the Roe v. Wade decision and then fast forward for 50 years to measure what happens to everybody. But we do have a next best thing in our field, and that is what we call natural experiments. So I'm going to give you two very relevant examples as I answer this question. The first natural experiment I'll talk about comes from the Roe era. It's 50 years old. So when Roe v. Wade was decided in 1973, it didn't actually have the practical effect of legalizing abortion everywhere because 5 states in the District of Columbia had already effectively repealed their very clearly repealed their abortion bans, and abortion had become legal there. Now, in the academic field, I'm not sure if this is true anywhere else, but academics call these states repeal states in a lot of the literature, these states where abortion became legal before Roe. And just as a quick bit of intuition about how they afford a natural experiment, these states mostly legalized abortion in 1970. Roe was decided in 73. Birth rates in these states fell when they legalized abortion. But there's lots of reasons birth rates might have been falling. There's a whole lot of things going on in the country. There's change in social mores. There's a youth rights movement. There's a women's rights movement. The civil rights movement is continuing. There's changes in Vietnam draft policy. There's changes in educational policy. So you might be like, yeah, correlation isn't causation. And you'd be right. But what we can do is look at what happened in the rest of the country where abortion wasn't being legalized. Yeah, birth rates were falling there too, but not nearly as much. And so if you're willing to consider the rest of the country to be a counterfactual, which is a big if, then you could regard this as a natural experiment. And you could say to the extent that births fell more in the repeal states than in the rest of the country, we'll infer that that is the causal effect of abortion legalization. Now, don't get too frightened. I'm not about to have a whole statistics class, but I will say there's a whole lot more that we throw at this than this simple before-after comparison. We add all sorts of controls. We spend a lot of time examining pre-trends. There's a lot more to it, but that basic intuition will serve you well in thinking through the forecasts that I'm about to share with you. So what we know from the Roe era is that the legalization of abortion had profound effects on people's lives. It dramatically changed the ages and circumstances under which American women became mothers. That is particularly true for women of color, for young women, and for poor women. And then we also know, and we talk a lot in our Economist amicus brief, that it then had enormous downstream effects on women's lives, which is not super surprising given the outsized role that reproductive autonomy plays in women's economic lives. So we know these things, and it was pretty frustrating to a lot of economists to see this false information put out that we have no awareness and no ability to know the causal effects of abortion access. And not only do we know the effects of Roe 50 years ago, but we've got a pretty good idea of what's going to happen now that it's been overturned. So I maintain a database of U.S. abortion facilities. It's publicly available. You can find it at Open Science Framework if you would like to download data on distances. And using that database, I track how distance to the nearest abortion facility, brick and mortar abortion facility, is changing. So here's a map showing you the landscape of distance before the Dobbs decision on May 1st, 2022. All the little dots are abortion clinics. The counties are shaded according to how far away they are from the abortion clinics or abortion facilities. Darker counties are farther away. The average American woman was 25 miles from the nearest abortion facility before Dobbs. Less than 1% of American women were more than 200 miles from a facility. This is what that landscape looked like on May 1st of this year, with bans taking effect in full total bans, near total bans on abortion in the states outlined in red. Almost a quarter of American women have experienced an increase in distance. The average person in this group who's experienced an increase in distance is more than 300 miles away from the nearest abortion facility. It's not over. We're all watching as legislative and judicial battles over abortion policy and abortion access continue to play out. I do not have a crystal ball about what, when the dust settles, exactly what the landscape of access will look like. But here's a projection where states that the Guttmacher Institute believes are at high risk of total bans on abortion. And here's a projection, what if they all were enforcing total bans? About 44% of American women would find themselves farther away from an abortion provider than they were before Dobbs. And again, the average woman in that group would be about 300 miles away from the nearest facility. So those are forecasts of one measure of access changing. And there are a lot of other measures we could talk about, but I have limited time. But that's forecast of how distance will change. How do people respond to distance? Some people are just finding a way. I'm not saying it's easy. People seeking abortions are often in really difficult life circumstances, but this is of such importance to their lives that many of them are, bringing in family members, getting loans, finding childcare, figuring out time off work, like scraping, scrimping, saving, risking, triggering an abusive episode with a partner, but they're figuring out a way to get there. But others aren't. They're trapped by distance. They're trapped by poverty. They're trapped by other circumstances of their lives. And I have forecasted in a new paper that's forthcoming in JPAM that is available on request as a preprint. I have forecasted how many people are likely to be trapped. The way I do it is by taking advantage of another natural experiment that arises from changes in distance that occurred even before Dobbs. Even before Dobbs, there were hostile states that were attempting to regulate providers out of existence and were succeeding in some cases, causing distances to go up. Even before Dobbs, there were states that were supportive of abortion rights that were, for instance, expanding the ability of advanced practice clinicians to provide abortions. That was allowing more rural health facilities to provide abortion and distance to go down. All of those changes in distance that occurred in the decade before Dobbs, those are a natural experiment. And what I do is I line them up against how changes in distance correlate to changes in various outcomes. I use a super fancy model. I can't resist showing you a bunch of Greek letters. There's a super fancy model. I love it. I love talking about stats. I won't go there now, but it's in the paper. Here's what I find. Distance matters hugely. a lot of people imagine that nobody would be trapped by 100 miles distance, right? Like I'm a upper socioeconomic status white lady in Vermont. I got 4 teenagers. If one of my teenagers needed healthcare in New York City, 6 hours away, we'd get in the car and drive there right now. I would like hang up if I needed to. But that's not the circumstances that a lot of people seeking abortions are in. And in fact, what we find is that even 100 miles, which might not seem like anything, even 100 miles one way will prevent about a fifth of people who want abortions from being able to reach a facility. It can have a really large effect on their lives. And if you take those results and take these changes in distance that we're seeing and forecast what's probably happening out there right now, probably right now with the current bans, the current total bans that we're seeing enforced, my prediction is that about probably 78% of people, let's say 3/4 of people who want abortions, are able to find a way to get out of these banned states and reach a facility. That leaves about 1/4 unable to get out. I don't know if you think that's a big number or not. I think that's a big number. That is in these areas, a significant fraction of people who want to access healthcare who are unable to reach a provider. If the full set of bans that Guttmacher is forecasting were to ultimately take effect, which is an if for sure, we would have a similar fraction of people trapped across a wider region of the country. And in total, in terms of absolute numbers, we would be talking about, in that scenario, in 1 year, about 80,000 people who want abortions and would have been able to obtain them if Dobbs had not been decided the way it was, who are now trapped by distance and poverty and abusive relationships and not reaching facilities. And I also can forecast, based on behavior we saw before Dobbs, that while some of those people are going to find a way to self-manage an abortion, what we saw before Dobbs was that most of them didn't. And my forecast is that about 55,000 give birth as a result of being unable to reach a provider. So I want to stop in 1 second because I want to hear everybody else and talk about all of these other outcomes that are occurring. I'm predicting a couple of sets of outcomes, but I'll simply preview a few things for you. We know that people seeking abortions are disproportionately in difficult life circumstances. A lot of them are already parenting, they're adults, they're low income, they have limited access to credit. We know that a birth occurring in this circumstance can be extremely challenging for them and their families. And so in the Economist Amicus brief, we lay out the reason to believe that in this particularly vulnerable population, the ramifications of not being able to reach a provider are likely to be quite high. If you would like to stay tuned to see people measuring this, we're waiting on data is the short answer. Like, we don't have all the measures of the outcomes yet, but I have an abortion access dashboard where I am tracking changes in distance, facility operations, and appointment availability, which we are surveying and which is limited in quite a few places. And I would also stay tuned. Scholars are waiting for new releases of data on abortions, on births, on economic outcomes, where we'll basically test the predictions that I've just given you. But for right now, they're predictions. I'll stop there.
Thank you, Professor Myers, for that really informative presentation. We'll save questions for you until the end. Now I'd like to turn to you, Dr. Parrott. As a practicing OBGYN and abortion provider for many years, please give us your perspective on changes you've been seeing in the abortion and reproductive health landscape, including what shifts you've seen over the last year since the Dobbs decision. Also, we know that abortion restrictions disproportionately impact communities of color. Can you speak about these impacts as well?
Sure. Thanks so much for inviting me, and thank you all for joining. As you mentioned, I am a practicing OBGYN and an abortion provider currently, and have done so for several decades now. And I think one of the most important things to keep in mind is that the crisis that we're facing in abortion access did not begin and will not end with Dobbs. We're seeing a lot of conversation in the last year around what's happening on the ground, what's happening with abortion access. And so much of that is framed in a way that suggests that this is a brand new issue. And as somebody who has been providing this care for quite some time, I want to be really clear in saying that Roe essentially did not exist for many people in this country long before the Dobbs ruling. And with that in mind, though, I think it's important to also name that we can both grieve the loss of Roe and also in the same breath acknowledge that it has never been enough. When we look at what abortion access has looked like, certainly over the course of my career, it has become increasingly and progressively more difficult to provide from a healthcare delivery standpoint, but most importantly, to obtain for individuals who are seeking this care. We began to see the dismantling of access, protections for access to abortion as immediately following the Roe ruling. And this is, again, my plea to you to really talk about and to think about this crisis in this long arc of history. As recently as quickly as 1975, right? We know Roe was ruled in 73. In 1975, immediately we saw the passage of the Hyde Amendment. And that's critical because what it said very clearly is because there was not a big outrage from most folks, even those who were actively supporting Roe, who were actively supporting abortion access. And what legislators saw very clearly in that moment was that the public had an appetite for limiting access to this basic human right for some people. And it really is embedded in this idea of deservedness around bodily autonomy and control. We cannot disconnect those things from the fight that we are engaging in around abortion access. So if we acknowledge that the dismantling of constitutional protections for Roe began almost immediately after the Roe ruling in 1973, then we can see how we got here today. And this progression, this chipping away, this steady chipping away of access to abortion at the local level, at the state level, and now at the federal level is part and parcel of a long strategic plan. What does that mean for me as a doctor when I go to take care of people? How has this changed in my own practice? It means that I'm traveling longer distance to take care of people, right? Because folks can't travel. We heard Dr. Myers talk about the distance that people travel to be able to get this care. It has, as a result of that, and knowing that many people cannot, it's also shaped the behavior of abortion providers. And many folks are flying in to places where they need more providers because the number of people seeking care in the places where it is less restricted continues to grow. But I want to, say as well that is a Band-Aid solution. Right? It isn't the ideal way to provide healthcare. Ideally, your care should be provided by somebody who lives and works in your community, who's familiar with you, who speaks your same language, ideally who looks like you, who has shared lived experiences. That is the way we see improved health outcomes for folks, not me flying into a community that I'm not grounded in, that I'm not familiar with, taking care of people. But here we are. So provider behavior has changed. It has become much, much more hostile to be an abortion provider. So, what that means for me is concerns around safety for myself, for my family, particularly for somebody like me who's public in the work and who speaks about my work, both on the Hill and legislative spaces, but also in the media and public spaces. So being mindful of what I share about my personal life, verbally certainly, but online as well, and looking for ways to protect my family. Those threats are nothing compared to what people seeking abortion care experience when they are jumping through these hoops that are designed to be insurmountable. We have to say over and over again, very explicitly and without equivocation, that every ban that is passed, every restriction that is passed on abortion is designed to eliminate all abortion, period. That is the goal. And so whether we're talking about trap laws and parental consent laws or age restrictions or insurance bans on abortion coverage or provider bans, right, mandating that only OBGYNs or only physicians can provide abortions, All of those are designed to limit access, and it thrusts people into this limbo and an extremely stressful situation trying to navigate a system that is set up for them to fail. So I'll stop there.
Did you want to comment on the impacts on communities?
Yes, thank you for reminding me. Yes, absolutely. So, that's such an interesting question because we hear this statistic a lot, and I know where it comes from in the Guttmacher data. And recently, I've been questioning those numbers a bit for a couple of reasons. When we look at it at the broad landscape, there is no question that folks who have been historically and are presently marginalized from healthcare systems more broadly are also marginalized from access to reproductive health care and abortion care specifically. And so we're talking about folks living on low incomes, young people, communities of color, those reliant on the government for their insurance coverage, right? All of those folks tend to be marginalized from many of our healthcare systems. And so that presumes that they will also have decreased access to contraception, an increased likelihood of having a pregnancy and subsequently needing an abortion, right? That's where we get these numbers around. And then we ask, right? Researchers go in, we talk to folks in the clinic, we could collect demographic information. But there's a couple of things that are important about this data reporting for abortion. One is voluntary. Right. And so we're not getting uniform reporting around who is accessing abortion and under what circumstances, except in the places where it is mandated by legislation or it is done voluntarily. And that tends to happen in independent abortion clinics, outpatient abortion clinics. What we're not getting a reporting of abortion numbers from private practices. We're not getting abortion reporting from hospital systems. And most wealthy white women get their abortion in those places, not in outpatient centers, right? So when we repeat this number around Black women having higher rates of abortion, having a greater need for abortion, my hope is that we interrogate a little bit what the true denominator is and how we're counting those numbers, because I don't know that we're telling the whole story. Regardless of whether that number is 100% true and everything, we want to claim it completely or not, we know that folks who are experiencing marginalization from all of our systems also have a more difficult time accessing this care. And this is important because, when we think about what it means to access your abortion in a private practice, and I've worked with providers who aren't even coding them as abortions. They're coding them as miscarriages. They're coding them as pregnancy losses. So it doesn't go in the patient's medical record. They don't get labeled as providing abortions, and it flies underneath the radar. And so when we look at the way that abortion is stigmatized, the folks who are marginalized from care, then we see this perfect storm of inequity. And often what we find is that women of color and Black women specifically tend to exist at the intersection of these oppressions, and thus a disproportionate need for broadened access.
Dr. Parrott, last week, a federal appeals court ruled to restrict access to the abortion medication mifepristone after concluding that the government didn't follow the correct process when loosening regulations to make it more easily available, setting up a likely Supreme Court review. Tell us your reaction to this and the potential impacts.
So the first thing I want to say is that mifepristone is still available. What we don't want to do is write about this or talk about this as if folks can no longer get medication abortion. So the ruling is not being put into place yet. And so medication abortion is still legal. It is still, as long as it's not banned in the state where you live, this medication is still available. That's the first thing. When we think about the impact of this ruling is similar to the impact of every single ban that's passed. It is designed to cause chaos and confusion. It is designed to make people unsure about whether or not they can legally access this medicine, to leave them stuck and frozen, and ideally carry this pregnancy to term because they are forced to do so. And that is exactly what is happening. We get calls frequently. The doctors in our network are often talking about this, that folks are calling clinics, calling their offices, Is it still legal to get this medication? Can I still obtain it in this state, in this place, in your practice? So the chaos and confusion on the patient side is real. It's also true on the provider side. So if you aren't steeped in abortion rights conversations and reproductive health and abortion and reproductive justice, then you may not know that this is still available and that you can continue to provide this care. Again, none of this is accidental. It is all by design. The other thing that I'll say, to wrap up this part of the question is really just acknowledging very clearly this question around whether or not the FDA went through the appropriate process in order to approve this medication. What we don't want to do is to begin supplanting legislative opinion for medical evidence. Those two things are not the same. We should not be legislating medicine. And in fact, we do not legislate medicine in any other way, shape, or form other than in the reproductive healthcare space. And now we're beginning to see that correction in gender affirming care as well. But those are really the only two places where we see the government stepping in and determining, even as a physician, what I can say. Forced speech, limitation of care, right? And so the FDA process is a rigorous one that has been in existence. And let's make no mistake, this medication had been used for decades in other places, right? But even prior to the FDA approval process, there is no question this medication is safe, it is effective, and it has been for decades. So this is not about the medicine. This is not about the science. This is not about safety. This is about ideology and political theater, and we have to continue to remind people of that.
Dr. Parrott, clearly, doctors are facing many challenges practicing within this most politicized area of medicine. How are doctors fighting back?
So part of the work that we do, not part of, the entirety of the work that we do at Physicians for Reproductive Health is organizing and mobilizing our physician colleagues. People go into medicine because they want to help people be well. They want to care for their communities. They want to treat, to heal folks that need it. And abortion care is part of that care. So what we're finding for healthcare providers is that tapping into that passion for justice that brought them to the work is really key in organizing around expanding access to abortion care and reproductive health care more broadly. That looks different ways depending on where you are. So your approach in New York is going to look very different than your approach in Mississippi, but they share some commonalities. The work that we do must be informed by people that are on the ground. We're talking about the Dobbs ruling and the impact of the federal access to abortion at a federal level, but this fight began at the state level and it's being carried out at the state level at this moment. And there are folks who have been on the ground since 1973, organizing, activists who've been fighting against this. And what the work of healthcare providers is not to go in and to decide that we know the strategy and we're ready to lead the fight, but instead to partner with community folks, grassroots organization, folks, advocates and activists on the ground to be able to leverage the power and privilege that we have as physicians, right? This white coat privilege that we carry, and understand what our positionality provides and how we can use that to shift public health outcomes and certainly public policy and legislative change.
Thank you, Dr. Parrott. Now I'd like to turn to Kate. Kate, as a reporter for the New York Times, you've written about the shift in public attitudes since the Dobbs decision. What are the most significant changes you've seen and what are their impacts?
Well, first of all, thank you for having me. I just want to say it's so interesting being the third person to speak here because, what Dr. Parrott and Professor Myers are talking about really are the incredible nuances of this debate and how careful we have to be. And, the reason, I was just telling this to my kids the other day, the reason I got into journalism was to explore the nuances behind things. I've always been sort of driven by stereotypes. So just to hear these questions, it just shows what an incredible beat this is and what a fertile area it is. No pun intended. But in terms of, I really come at this, I had done a big story on abortion in 2003 for the 30th anniversary of Roe. So I was approaching it when I started covering it 2 years ago, just as we were awaiting the outcome in Dobbs, I was coming at it 20 years later, and there had been an enormous shift between 2003 and 2022. When you look at just sheerly the legislation that was passed restricting abortion. But to me, what's been most interesting to watch is how public opinion has shifted, both really after about 2010, but certainly in the last 2 years, or in the last year since, as Texas banned abortion in September of 2021, and then after June of 2022, when the Dobbs decision came down. So to me, the biggest changes really are first culturally, which is that if you look at the polling, the percentage of people who now say abortion is morally acceptable, that is now a majority of Americans, that really hasn't been the case for a number of years. The other number that I find interesting is the percentage of people who say that abortion should always be illegal in every case. There should never be a case for abortion. That percentage is at a record low. I think what's happened here is that really, as long as Roe was in place, people didn't have to think about what abortion meant. Now that it is, they have to reckon with the effects of it. So they have to see, frankly, like what abortion actually is, like what abortion describes. When Dr. Parrott was talking about this question, which I've really long wondered, when you go to a private doctor's office to get an abortion, or when you're in a hospital, what are they reporting? Many times a woman comes out of that procedure and she will say, well, I had a miscarriage and they did a procedure. Well, that procedure was an abortion. Anti-abortion advocates will say, no, that's not what we're talking about. But really, abortion is a procedure. So people are reckoning with all of these questions. And so I think as that has happened, their attitudes on abortion have become more liberal. I said small L liberal. I think they are thinking, oh, there are cases where abortion, should be legal. And I think many people now think we really can't have this hard and fast. There never should be abortion. The other change, so that's sort of the cultural change, but the political change has been huge. And this is really where you see the polling numbers have changed. And also you see you can understand what's happened in the last year. So politically, abortion has always been, since Roe, and really since the 1980s, when the social conservatives made this a real issue for the Republican Party and it went into the Republican Party platform, abortion was an issue that motivated Republican voters, that motivated anti-abortion voters. What we've seen since Dobbs is that it has really motivated Democratic voters. And in fact, Republican voters, anti-abortion voters, are much less likely to vote on this issue. They're sort of walking away from the issue, whereas now all of a sudden, all these people who for 50 years, really that's every woman of reproductive age, all of those people are saying, wait, what? This is illegal now, and they're fighting to restore abortion rights or to protect them in the states that still have them. So I think the political change has been enormous, especially among young women, because those are the women who are most affected. So that flip is really to me the most significant change.
Thanks, Kate. The language of abortion can be so fraught, politicized, and confusing. Even the word abortion itself can mean different things to different people, as you've reported on. How do you think about the language that you use when you're writing? And what are some, key terms that are often misused or confused in the media?
Yeah, so this is something where I think the ground is shifting even for us as journalists. And you really have to put a lot of thought into the language this is not an easy beat to cover. You have to put a lot of thought into every word choice because people are watching it. Both sides are watching. So as you mentioned, the big question to me, and this is really an interesting sociological question, is what is abortion? Is abortion the thing that a woman gets, that a wealthy white woman gets when she goes to see her doctor? Or is it only the thing that happens in a Planned Parenthood clinic to someone who is who's there on medical assistance? The reality is it's both. Abortion is abortion is abortion. So when we talk about abortion, it is a procedure. It's not, so there's no such thing as an elective abortion. I think anti-abortion advocates would say we should describe elective abortions. That is not a term. So this has been, I had long thought, that the terms that we had watched out for were, we never said pro-life or pro-choice because those are political terms. And so we would say supporters of abortion rights or opponents of abortion rights. We try not to say abortion supporters, because I think a lot of people who support abortion rights would not necessarily say they're not exactly rallying, rah abortion. They don't want to be described that way. So those were the obvious ones. But the other terms that I think people don't necessarily think of are for instance, pregnant woman, are you going to say pregnant woman or pregnant person? Oftentimes that person is described as a mother. She is not a mother yet. And because there's so much valorization about and celebration of motherhood in this country, when you talk about a mother and the idea of a mother going in for abortion, it's sort of it's this idea that this is a woman with a baby the baby is being taken from her. It is not a baby until it is born. It is not a fetus until about 8 weeks when it is an embryo. So in fact, most abortions in this country happen, I think Dr. Parrott can probably confirm this for me, but before 8 weeks, when the fetus is actually an embryo. So it really is, you have to look at the language you're using, because the anti-abortion side has long tried to make this about a very graphic procedure about, this is ripping a child limb by limb. And that's really not the case in the large percentage of it. It's not the case. This is a fetus or an embryo in most abortions in this country. It's not even a viable fetus.
Mm-hmm.
I think also another obvious one is partial birth abortion. That was really what's interesting to me, and what sort of reinforces the idea that we have to watch out for our language, is that when you look at the polling, support for abortion began to decline in about 2007, when there was a lot of talk about partial birth abortion. And that was intentional, because the intent was to make abortion seem this gruesome procedure, that it was killing a child. And so partial birth is a very loaded term. So we have to be careful about that. Fetal heartbeat, with laws describing bans at about 6 weeks, describing them as bans after a fetal heartbeat. That is actually, it's not a heartbeat. If you look at the medical literature, a heartbeat does not develop, chambers of heart don't develop until later into pregnancy. So at 6 weeks, what you have is cardiac activity. That is difficult, however, when states like Ohio describe their laws as a fetal heartbeat. And even in the legislation, they don't say 6 weeks. They say when a heartbeat can be detected, and that physicians would dispute that that's actually a heartbeat. Another more recent term that we have to watch out for is the use of chemical abortion to describe medication abortion. It's a little bit like saying, chemical anti-inflammatory. I mean, it's a redundancy, right? So chemical is made to make it sound bad, like we're sort of slowly torturing the fetus. So ACOG, the American College of Obstetricians and Gynecologists, maintains a very useful list of terms that can be disputed. Some of them I just went to look at it before we got on the webinar, and I was even surprised to be reminded of them. For instance, they don't like the use of womb, because they believe that the term womb it's not a medical term, and it implies, again, sort of this like cozy space. It's the valorization again of motherhood, and that we should be using the term uterus. They actually don't like the term abortion provider, because what they are trying to underscore is that physicians who provide abortions actually are physicians who provide abortions are capable of, or they're trained for all sorts of medical conditions. It's not like their abortion is the only procedure they're doing. So that, I think those are some of the terms that I look out for. That ACOG list is very useful to journalists. But again, as Dr. Parrott said, we have to remember, the main thing you have to remember is when someone uses a word, when someone uses a term, what are they trying to do? Are they trying to create confusion? Are they trying to sort of celebrate motherhood and make you think that abortion is a horrible thing? That's really what you have to watch out for.
Thank you, Kate. I would like to ask you one more question before we open it up to audience questions. So, as a journalist on this beat, there certainly is a lot for you to keep up with in this constantly shifting story. You've been covering abortion issues in various states, including Texas and Ohio, for example. What are the big battlegrounds in the months ahead?
Well, I think the Ohio abortion referendum is going to be, really big. That's the next sort of big battleground. Abortion rights supporters they have won now, I think it's 6 out of 6 ballot initiatives last year. So this is going to be the next one, and seeing whether Ohio backs an amendment that would essentially restore the protections of Roe in Ohio, saying that until the point when a fetus is viable outside of the womb or the uterus, as we say, that abortion should be allowed, and that the state can regulate it after the fetus is viable. So that's really, it's an interesting question, because Ohio is a conservative state, but what we have seen even in conservative states is that a lot of people think that abortion should be a private decision. They may not love abortion. They may not love the idea of their daughter getting an abortion or their wife getting an abortion or themselves having to be put in a position where they have an abortion, but they do think that these are healthcare decisions and that these should be left up to women. So Ohio is one that I'm watching. I'm also watching that because of the question of viability, because it's sort of, if Ohio backs that amendment, it sort of suggests that the country really did support the basic protections of Roe, which is up until viability. But I'm also watching the court cases. What's happened now is that now that there is no federal constitutional protection for abortion, abortion rights groups are trying to establish protections for abortion in state constitutions. Some state constitutions have recognized that right. It is not necessarily, it doesn't become part of the firmament as much the way it did in Roe because the makeup of those courts can shift. So what happens are anti-abortion groups then file new laws, bring new suits. The makeup of the courts has changed because perhaps the governor of the state has changed, and now it's a Republican, and that person has appointed new judges. But I am very, very interested in what happens in some of the court cases, particularly in these conservative states. So in Wyoming, in Utah, in North Dakota. I think those are going to be the next places to watch, because they are going to tell us something about sort of the support for abortion rights outside the traditional party lines of Republicans are anti-abortion and Democrats are abortion rights supporters.
Thank you so much, Kate. I'd like to take some audience questions now. We have a question for anyone on the panel. Do you see the Dobbs decision as the primary driver of maternal health deserts, or is it just one of several drivers? So getting at the issue of areas that have little to no maternity care.
I'll start and then you all can jump in. So thanks for that question. And one of the things that I love best about that question is that it really makes this connection between maternal health and abortion access. And Dr. Myers mentioned a bit about that, right? The increase in mortality being tied, maternal mortality in particular being tied to restricted abortion access. And that's particularly critical in this country when we see inequitable outcomes regarding maternal morbidity and mortality, with Black and Indigenous and Native women bearing the brunt of these inequities. Certainly, when we think about the impact of maternity deserts, I think that they are connected in some ways. It isn't the whole story, but it's an important piece of the story. There are a number of reasons why maternity deserts occur. And we're more likely to see them in rural communities for sure, and in places where folks are living on low income and identify as poor. Right. And so even in the District of Columbia, for example, where the majority of the median income is probably twice the national average, we have one whole entire section of the city that has a maternity desert. And so we see that these patterns and following poverty in particular with access to maternity care. And so what that means is that the folks that are impacted by abortion restrictions are also the same folks that, should they carry their pregnancy to term, don't have access to an OBGYN, can't get in early for care, or more likely to die during pregnancy. So there are very deep connections, not just between maternity deserts, but the funding of maternal health care more broadly in community, and the impact of abortion restrictions on the same community. So we have to, I think, move out of the siloed thinking about this issue, right? We're talking about abortion, or we're talking about maternal health, or we're talking about child health or perinatal health. All of this is happening in the same body. It's the same individual. It's the individual that lives at those intersections of those oppressions. So whether we're talking about maternal health or abortion access or infertility treatment, we see that those inequities are experienced by the same community.
Mm-hmm. Professor Myers, we have a couple questions for you. One, are you currently tracking economic outcomes related to Dobbs? Is this something that you can share? And then another question, can you talk a bit more about the economic impact and context to your report in the business?
My answers may disappoint because there are some real statistical challenges here. So let me start with what we know about the Roe era. We know that abortion legalization 50 years ago allowed women, particularly young women, particularly women of color, to avoid uh, severely mistimed entrance to motherhood and often marriage in that era. And that as a result, we've been able to see statistically that they were much more likely to be able to finish their education, avoid poverty, enter higher paying jobs. Like, we see these impacts on their lives. I know that economists, including me, will be looking at these same outcomes as a result of the Dobbs decision. We don't have immediate evidence for one reason, because we're waiting on data releases from the US Census Bureau. So there's no way to really kind of track it real time. But there's actually another really big challenge here, which is that when we're talking about a set of state bans, we're talking about an inequality story, right? 75% of the American population has not been affected by a change in distance, although some of them are struggling with access because of lack of appointment availability, because providers are getting slammed in haven destinations. But a lot of the American population hasn't experienced a dramatic change in abortion access because of Dobbs. For those who have experienced dramatic changes, a lot of them are finding a way. There is a significant minority whose lives are being dramatically impacted. Statistically, they're really hard to identify in census data and Bureau of Labor Statistics data. Like, it's impacting their lives. I think there's every reason to believe that based on what we know about the link between motherhood and economic outcomes. But I think it's going to be a while before we're able to come up with some research designs that let us really tease that out and measure it. The place where I've been more hopeful is that Diana Green Foster at Answer, who was the principal investigator on the really influential Turnaway study, which produced some of the most important contemporary evidence on the impacts of abortion access on economic outcomes, has planned and is working on implementing with co-authors an updated version of that tries to look at what happens to people who had appointments at abortion facilities that they had to cancel because of a ban taking effect. But it's very preliminary, and my understanding at this point is that there's been some challenges with building a big enough data set. So, like, this is a big unknown. I wish I had an easy answer for you, but it's an area where a lot of people are working, and there's some real challenges with the approach.
Another question for the panel. Can anyone discuss the Biden administration's proposed changes to HIPAA, the opposition against those changes, and how the new policy will impact states with and without abortion restrictions?
I don't know if this is referring to the EMTALA decision about requiring emergency care for abortion. I don't know. I don't know the proposed HIPAA changes. Dr. Parrott, maybe you do?
Yeah, I can speak a little bit about it. I don't know about I don't pay a lot of attention to the opposition around it because the work is the work is the work. But yeah, so what I believe, and certainly the question respondent can, or presenter can respond if this isn't what you're talking about. In April, the Office of Civil Rights and HHS issued a notice of proposed rulemaking to modify the HIPAA privacy rule in a way that is designed to strengthen privacy around protected healthcare information. So I think that that's what the question is really grounded in. And what the rulemaking is designed to do is to strengthen these privacy protections by prohibiting the use or disclosure of protected health information by a regulated entity for a couple of purposes, right? So if this is a criminal or civil or administrative investigation into or against anybody in connection with seeking, obtaining, providing, or facilitating reproductive health care, where this care is lawful under the circumstances in which it can be provided, and also prohibits the use of the disclosure of protected health information of any person for the purpose of initiating such investigations or procedures. And so what we're talking about, and so that's really wordy, and I think sometimes it's kind of hard to follow, but what they're saying is, like, stop telling people's business, right? Like, personal information is personal information. The HIPAA rule is what it is. The reason why we're seeing this expansion of rulemaking is really around the risk that people engage in when they're seeking medical care. The reality is that many folks who are arrested, prosecuted, jailed for their pregnancy outcomes come into the grips of the carceral system because they sought medical care, and the police were called by a healthcare provider, a social worker, their physician, a nurse who saw them. Sometimes the calls and the reporting is malicious, right? We've seen cases where folks who are aligned with anti-abortion groups are active in those groups or providing care and are then calling the police on patients. Oftentimes it happens because providers are confused around mandatory reporting laws. They're not sure, am I supposed to report this? Am I not supposed to report this? So this rulemaking is designed to be very explicit in saying, this is not okay. You cannot disclose this information. And in fact, you can be penalized for inappropriate disclosure of protected health information.
Another question from the audience. We understand that OBGYNs are leaving abortion ban states. What can their employers, e.g. hospitals, do to retain them aside from working to repeal the bans? Are there any short-term measures they could take?
Hospital, oh, I'm sorry.
No, I'm more interested to hear from you.
So physicians and hospital associations are powerful entities. The idea that they could not lead the fight to reverse this ruling, to me, is nothing short of a farce. This is where organizing comes in. We are operating within a for-profit system of healthcare. So there's a lot of money on the table, for better or worse. And so imagine what it could look like if we saw these big hospital systems, these big medical systems say, this is not in alignment with care. This is not in alignment with our medical and ethical principles. And that would do more than these individual Band-Aid solutions to address this issue. Everybody has to understand, regardless of whether or not you live in DC or you live in New York or you live in California, no place is safe. No state is safe. And we can see very clearly that when one domino falls, the rest are not far behind. And so, yes, there is work that these folks can do, and they must be engaged to do it. The tricky part here, and then I'll step aside and let you respond, Kate, is that we've also paralleled with these abortion restrictions, we have seen a similar increase in the number of hospital systems and practices that are bought by Catholic institutions and religious entities. And so that is a direct conflict of interest when we think about what we're advocating for in this moment and the ways that religious ideology impact care in places where the hospital system or the institution is owned by a religious organization.
Yeah, one thing I would say is I've been very interested in the shift in the AMA, the American Medical Association's position. If you look back to the, long before, like late 19th century, the AMA was actually pushing for abortion restrictions because they were pushing against largely women who were providing these services. So now you have the AMA coming out and supporting this and really underscoring what more and more people are discovering. The idea that abortion is healthcare has long been a slogan, but people, I don't think, have understood what that meant. They thought, what abortion rights supporters are saying is that it should be one of the suite of things you should be able to get as part of your healthcare. What doctors are saying now is, no, there are cases, abortion has to remain available to us as an option when we are treating a patient for a number of reasons, not necessarily because a woman wants to terminate a pregnancy, but because the termination of a pregnancy is part of her care for something else. So that's been interesting to me. And just the fact that the AMA is now coming out and saying this has caused, in their words, chaos in hospitals, that has been huge. Doctors are stepping up and saying, we are forced to be lawyers. We're not trained as lawyers, but we are being forced into the position where we have to think of the law first and medicine second. That's not why we went into this. The other thing I would say is that what was really striking, you did see a lot of attention paid when the Texas Medical Association came out with a letter that said, we are confused, to the state, saying we are confused. We want to know what the exceptions are to this. I think where this debate is going to shift is around this question of the exceptions in banned states. And that's only because that affects public opinion so much. But this is what the doctors were saying, which the medical association was saying, was in what cases can we provide this? The state is not being clear enough, because as I think someone mentioned earlier, what you have are legislatures trying to legislate healthcare. They're not doctors. You're practicing medicine without a license in many cases. That's what these medical associations are saying. And I think those statements can be very influential in the political.
Can I say one thing quickly about the exceptions, because that's such a critical point. We often write about and talk about exceptions as if they, in a way that suggests that, well, at least the ban isn't that bad because there are some exceptions that are in place. And I want to just say super clearly that exceptions provide no protection. As somebody who has tried to help folks navigate these exceptions, it is nearly impossible to do so. The logistical barriers, the social barriers, if you're a young person who is seeking an abortion and your parents hold your insurance and you need to figure out how to get this care, there's states that mandate that if you are seeking as part of this exception ruling, your abortion because you have been raped, that there needs to be a police report and a documented investigation, right? So all these exceptions are not what's going to get us where we need to go. We need to stop glorifying them in any way and writing about them as if they were at least an incremental solution to this desert. It's absolutely not true. And the last thing I'll say that I can't resist, because you brought up the AMA, Kate, is that we have seen this shift in the AMA recently. That is not accidental. That is because of the organizing of physicians that are working within that body to make these changes possible. We've seen similar changes with the American College of OBGYN. It is not the good nature of people in leadership that causes this to happen. It's the pressure from grassroots on grass tops that makes this a reality. The AMA came in, you're absolutely right, and was advocating against abortion, not just because women were controlling this care, but because Black midwives in the South were controlling this care. It's very explicit. It's the same way they came in to shift for obstetric care, to discredit midwifery care, to discredit the grand midwives who were also providing family planning, also providing abortion care. This is about profit, not about people. And that is what caused the AMA to move in, to prioritize doctors who were almost exclusively white men to be able to corner this share of the market.
Well, thank you so much to Kate, Dr. Parrott, and Professor Myers for this really informative discussion. Thank you to the audience for all of your great questions. I'd also like to thank the team working behind the scenes to produce this webinar, contributing editor Fran Smith, engagement editor Cassandra Garabai, project specialist Andrew Perez, and communications strategist Apps Mandar Bishu. We'll be sending you a survey asking for your feedback on today's program and for your ideas on other topics of interest for future programming. We hope you'll take a moment to complete it. We urge you to help support these webinars. You can find more information here on how to do that on the screen. And we will be archiving this webinar a little later today at centerforhealthjournalism.org. Thank you so much for joining us and have a wonderful day.